This lecture is on approaching undifferentiated dizziness in the emergency room. As doctors, we don't get to use the words dizzy or lightheaded because they don't really mean anything. They're not communicating any piece of information. If you come to me and say a patient is lightheaded, I can't tell if the patient is lightheaded because of syncope or pre-syncope, or if this is more vertigo, disequilibrium. So whenever you approach a patient with a chief complaint of dizziness or lightheadedness, you should try to figure out, is this more syncope, pre-syncope? Is this more vertigo, or does the patient feel like has some disequilibrium? Sometimes the patient will give you a story that's very clearly one or the other. Other times you'll get a story where the patient gives you some presyncopal symptoms and some vertiginous symptoms, but more of one than the other. In those cases, you have to kind of pick and choose which direction you need to go, and you might need to simultaneously approach the patient by working out for syncope, pre-syncope, but also evaluating for vertigo and disequilibrium. But most of the time, you should be going in one direction or the other. But this is our first branch point, so let's talk more about syncope, pre-syncope. I lump these two together, syncope and pre-syncope, because when you go on looking for further reading on this topic, you'll find out that there aren't many articles for pre-syncope and how to approach that, but there's a ton of articles on how to approach syncope. It's usually because people work them up the same, but disposition them differently. So you want to divide these into three categories. So one is cardiovascularly mediated syncope. The other one is hypovolemic syncope, and the third one is neurally mediated syncope. For cardiovascularly mediated syncope, we want to think about, is there a Tachy-Brady syndrome going on? Is there WPW, Brugada, prolonged QT? A whole list of things, including heart block, Mobitz 2, third-degree heart block, HOCM, and arrhythmogenic ventricular dysplasia. This is one of the few times in medicine, or in emergency medicine, where we actually care about the family history. You want to make sure to ask that there is no family history of sudden cardiac death or anybody with exertional syncope. And on the EKG, you're looking for specific things. For WPW, there's a delta wave. For Brugada, there's the bunny ear morphology, or the right bundle branch morphology in V1 through V3, and also having this saddle-like ST elevation or downward coving type ST elevation. For example, in HOCM, you have dagger Q waves, or can have dagger Q waves. Those are pathognomonic. And then in ARVD, you get that epsilon wave, which is a little ditzel that happens at the back end of the QRS. For hypovolemic pre-syncope or syncope, I'm looking for very specific things on history and exam. One is, do they have hypovolemia from decreased PO intake? Another one is, do they have increased output from nausea, vomiting, and diarrhea, and is that why they're hypovolemic? A third thing would be any sort of GI bleeding or bleeding in general. And the fourth thing is there any infection going on that may lead to an occult shock state? And lastly, the neurovascularly mediated syncope deals with vasovagal syncope. Your pain plus passed out, your blood draw plus passed out, or bowel movement plus passing out. So can I build a story for a preceding event of that nature that occurred prior to the symptoms? So when I'm working these patients up, I'm really trying hard to determine if I can build a story where there was a prodrome and where I could explain this event from either a hypovolemic cause or a neurally mediated cause. And remember, hypovolemic and neurally mediated presyncope and syncope usually have a prodrome, whereas cardiovascularly mediated syncope has no prodrome, right? Somebody just eating cereal and then all of a sudden passes out and wakes up with their face in the cereal bowl, right? Where they really don't know what happened prior to them actually losing consciousness. And this is where the branch point of presyncope syncope gets even wider, to where, if somebody actually passed out, I'm a lot more worried than if somebody just felt like they were going to pass out, right? Because if you feel like you're going to pass out, or if you feel presyncopal, then that technically means that you have a prodrome, right, prior to passing out. So if I can't build a linear story that you had a prodrome prior to your syncopal event, then I'm going to default to saying that this could be cardiovascularly mediated, because if we discharge somebody with underlying or undiagnosed cardiovascularly mediated syncope from Brugada, WPW, or prolonged QT, that's really bad, right? And that patient, if you discharge them, they go into VTAC, VFib, that patient's going to die very quickly. Whereas if we were to discharge somebody with hypovolemic or undiagnosed neurally mediated presyncope or syncope, well, it's less bad, and these patients don't die as quickly as with an arrhythmia, right? If somebody had a GI bleed that I just wasn't able to diagnose, I sent them home and I give them good strict return precautions, they're able to come back, and we can still save that person, right? The same with the hypovolemic person. Same with somebody with vasovagal presyncope or syncope. And this is the most important point. If I can't convince myself, either on history or exam or with any of the tools that I have at my disposal in the emergency room, that this isn't cardiovascularly mediated syncope, then you really have to err on the side of caution, because you don't want to discharge somebody with a potentially life-threatening disease that you haven't been able to rule out. And what's frustrating about these patients from the medicine or inpatient aspect is that you do these really whopping, large, expensive workups with ultrasounds, MRIs, echoes, monitoring, and a lot of the times nothing really comes up as positive. So the value in these largely negative workups, the value from the admission comes from the fact that we're able to determine if the patient is now stable, right? When they come into the ER, we don't have much information as to whether or not there's an unstable arrhythmia going on, but the more hours we accrue under monitoring that show no events, the more confidently we can say and discharge a patient, even when we are not entirely sure whether or not cardiovascularly mediated syncope is going on. And that's how I approach undifferentiated dizziness when we go down the first branch point, which is syncope. We will talk about how to approach vertigo disequilibrium in a different lecture.